Bismillahirrahmanirrahim. Now, today I'm continuing with the infection and the disease, that is infectiology. And previously I have talked on the rickettsial group of fever. Now, this is another type of infection which is called Q fever or curry fever. So this curry fever, why it is important to learn. Second question is it present in Pakistan, elsewhere in the part of the country? Although I have already said that the bacteria and the microorganisms which you learn, try to remember it as much as you can, because they are covering 40 to 45% of the internal medicine. Although it is a dry subject, but you make it more comfortable when you learn, you try to understand. I am Professor Sadi Haider, and I am honorary global professor of medicine without any name or fame or economics. So it's a free channel for everybody who is or who was listening this tutorial. This is a type of a tutorial, that is, it is a blog. The introduction is that the curry fever or the curry fever is a disease is caused by the infection with one of the gram-negative bacteria, which is called Coccidia burnetii, that affect the humans and the other animals. So it is zoonotic disease, purely a zoonotic disease. This organism is uncommon but may be found in the known reservoirs of the cattle, affected animals also, cattle, sheep, goats, and other domestic mammals, including the rodents, cats, and dogs. The infection results from the inhalation of the spore-like small cell variant and from the contact with the secretions of the animals, milk, urine, feces, vaginal mucus, or semen. Rarely the disease is tick-borne. Rarely this disease is tick-borne. The incubation period can range from 90 to 40 days. So bacterial involvement in this case is minimal. And this is very unique thing about it. Previously the Coccidia burnetii was classified under Rickettsia. Now it is a separate organism because it is not carried by the arthropods. And that is why it is separated, because of the other properties also. So it is rarely a tick-borne. The incubation period can range from 90 to 40 days. Humans are vulnerable to curry fever because of the milk, urine, feces, vaginal mucus, or the semen of the infected animals. Those who are handling these animals, they can be infected. Now, humans are vulnerable to curry fever, and infection can result from even a few organisms. Only the infective dose, which is called, is very, very few, rather than it is in millions. No, very few organisms can infect the animals, just like the mycobacteria. Only few organisms, rather one or two or three organisms can infect the human. But it is more than that. The bacterium is again the same one as previously told you, that it is the obligate intracellular pathogenic parasite. It grows inside the cells and completing the cycle and become pathogenic. And this is the gram-negative organism. You see, this is a very short bacillus. Some are in the form of the cocci, which are developing into the by the bacillus is the high power microscope you are watching. But immunohistochemical detection of the Coxsackie Burnetii is the sected cardiac valve, is a cadaveric valve of a 60-year-old man after postmortem examination with the Curie fever endocarditis, Siani, French Guinea. This was found in the zone, French Guinea. The monoclonal antibodies against the Coxsackie Burnetii and the hematoxylin were used for staining. Original magnification is 50, and it is seen in the valves, the cusp of the valves. Here you will see the organisms are there. This is direct evidence of the organism. The Curie fever can infect the heart. It means that the valves are involved. It means that it is the infective endocarditis. It is called the infective endocarditis. The reservoirs of infection, I already said, farms are there, specifically speaking in the Australia where a lot of farms are there, and in the part of the American countries and Switzerland and Kashmir and the other zones are very rich in farms. These are the two people who are watching and raising animal. The animals, they withdraw the milk from there, they are touching it, and the secretions are coming also from this nose and the mouth and other parts of the body. If this animal is infected, this secretion must or may travel into the human body, rather directly or indirectly through feces. Even the plants are there, in the feces, on the urination deposits on the leaves of these plants or the vegetables. If they are not washed correctly, then the organism can travel into the human, directly or indirectly, it means. And the global incidence is estimated at about 50 per 100,000 inhabitants per year. It is about 2000, research is of 2017-18. The Curie fever in endocarditis is estimated at 1 in per 10 raised to the power 6 inhabitants per year, 365 as a whole. And Curie fever represent in these participants about 5% of the cases of the nationally diagnosed endocarditis, 104 from 365. 5-6% overall endocarditis is caused by the Curie fever, although the infected persons may be 50 per 100,000. This is a global incidence. Whether this infection is important for our country, and this is the question. If it is this, according to the limited available literature, the seroprevalence of the Curie fever in Pakistan ranges from 4.6 to 40% in all livestock species, which are much in number in Sindh and specifically speaking in Punjab, and we are very rich in the livestock in Balochistan also, where the goats and lambs are there. And the humans are concerned, seropositivity occur in about 10.2 to 26.8% in the humans. Whether it is IgG or IgM, it means the past infection can have occurred and the patient came out himself. It is possible because of the immunity developed in the body and kills this organisms without treatment. It is possible that they will admit in your ward as the PUO, it is possible like this. So it is 26.8% up to 27%. It means that it is a higher rate, definitely higher rate, and it is a misdiagnosis. I will say it is a misdiagnosis because the Curie fever was only, I have seen in my 47 years of practice, only one case was presented in Aga Khan University Hospital. In the meeting, the Curie fever they have detected. Seropositivity and direct evidence were also demonstrated at that time. Because they have taken the samples of the vegetations, they culture it, and then after culture, the direct evidence was also positive. Now, the epidemiology overall, the pathogenic agent is found worldwide with the exception of the countries in New Zealand, Poland, and some part of near Poland area, Scandinavian areas. Very few cases are detected there. In New Zealand is zero, almost. Interesting thing about the New Zealand is that they have no snakes in this island. This island, and there is no snakes are found, whether poisonous or non-poisonous. They are free to move. You can camp easily at any part of the New Zealand. Although other animals are there, but snakes are not. Secondly, the zoonotic diseases are not very common in this country because of the very good, veterinary services given by the government of the New Zealand. The bacterium is extremely sustainable and is virulent. If it is positive, then a single organism is able to cause an infection, just like mycobacteria. Only one or two organisms are sufficient to cause infection. The infective dose is very, very low. The common source of infection is the inhalation of contaminated dust on the plants, on the farm, contact with the contaminated milk, meat, wool, and particularly the birthing products of the animals, placenta, etc. Ticks can transfer the pathogenic agent to the other animals themselves, but not the humans. So it is not a zoonotic disease directly in the form of the arthropod-borne. It is not arthropod-borne disease. Transfer between the human seems extremely rare, between human to human, and has so far been described in very, very few cases by the secretion of the human to the other human. Now, some studies have shown more men to be affected than the women because they are not very, very commonly involved in the duties of the veterinary services, which may be attributed to the different employment rates in the topical professions. At risk occupation include the veterinary personnel, stockyard workers, farmers, sheep shearers, animal transporters, laboratory workers handling potentially infected veterinary samples or visiting the abattoirs, and people who cull and process the kangaroos. This is a very important animal in Australia. The kangaroos and the hide tannery workers. The tannery, factories or foundries are also very, very high numbers are present in Pakistan. I always said that it is misdiagnosis. A person who was admitted in the ward, he was suffering from the fever of unknown origin. You have tried to detect it, but you are not able to detect it. And that is why it is a Curie for you. That is why it is called Q fever. This is a coccidiobality, and it can infect the contaminated dust and the contaminated hay occupational exposure and exposure to the infected products or the consumption of the animals. Only ticks are important from animals to the animals, not the humans. It can infect the humans by blood transfusion, also sexual transmission, very rare. It is not sexually transmitted disease. It will not be under the heading of the STDs. Contaminated food or water is maybe the source. Yes, contaminated meals, males, you will, open the envelope by your hands or by your teeth, then it will go inside. Only 1 to 2 organisms is sufficient to cause the infection. So this type of the organism can be used in a microbiological warfare. Aerosols, again, is again the same one, because the infected dose is very low. A lot of people can be infected. So it will cause the acute disease, that is it will cause the respiratory tract may be involved, as the pneumonia, the liver may be involved. The important thing is the target organ is the heart, which is involved. The clinical features now, the incubation period is usually 2 to 3 weeks. It may be up to 40 days. The most common manifestation is flu-like symptoms. Abrupt onset of the fever, with malaise, profuse perspiration, severe headache, muscle pain, the joint pain, arthralgia, loss of appetite, upper respiratory problems, and dry cough, pleuritic pain, chills, confusion, and GI symptoms such as nausea and vomiting, and it can cause diarrhea. About half of the infected individuals exhibit no symptom except fever. During its course, the disease can progress to the atypical pneumonia, because it is part of the atypical pneumonia, which can result in a life-threatening acute respiratory distress syndrome, ARDS. Acute respiratory distress syndrome, usually occurring during the first 4 to 5 days of infection. If it is inhalants, if you have taken by inhalation, it will cause the atypical pneumonia leading to the ARDS, and respiratory type 2 failure can occur in this case. Less often, the curry fever causes the granulomatous type of hepatitis. Granulomas are formed in the liver, just like sarcoidosis, the mycobacterium tuberculosis, and other organisms, syphilis for example, which may be as asymptomatic or become symptomatic with malaise, fever, enlargement, liver enlargement, and pain in the right upper quadrant of the abdomen. This hepatitis can result in the elevation of the transaminase values. Although the jaundice is uncommon, curry fever can also rarely result in the retinal vasculitis, but it is rare complication. The chronic form of the curry fever is virtually identical to endocarditis, because endocarditis may be possibility what is we call as the recurrent type or a subacute type of the endocarditis. Inflammation of the inner lining of the heart, which can occur months or decades following the infections. Decades. Whenever it can be remnant in the areas as a latency and can infect the heart afterwards. It is usually fatal if untreated. However, with appropriate treatment, the mortality falls to around 10% only. If you will detect and this type of a problem, you can manage it. It means that it is a manageable disease. Now this is some of the diagrams or photomicrographs. This is the what is called rash, which is present around the limbs and the abdomen, and it can be It is in this diagram. It is the entry through the upper respiratory tract. It can cause the pneumonia, etc. If it invades the blood, it will spread as a what is called as the coccilemia, just like bacteremia, and it will cause the SIRS, and it will cause the involvement of the heart. Vegetation can be formed. It may be hematogenous. It can cause the cochlear shock syndrome, that is called as septic shock. So it is the urine actually. It will not exist in the urine, in feces or other secretions. Just in the cattle, they are excreting out, but in the humans it is not this form. It is intracellular obligate parasite, so it will remain inside. The heart is involved. Definitely, it is the leaflets which are showing the vegetations, and otherwise the limbs are concerned. It can cause the thrombosis. As vasculitis occurs, and vasculitis can cause thrombosis. Diagnosis now is depending upon serology nowadays. Antibody response, ELISA for example, or some agglutination tests can be done. Serology allows the detection of the chronic infection by the appearance of high levels of the antibody against the virulent form of the bacterium. The molecular detection of the bacterial DNA is increasingly used because of the availability of the polymerase reaction, PCR, and contrary to the most obligate intracellular parasite, Coxiella burnetii can be grown in the axenic culture. This is a specific culture. This culture is technically very difficult and not routinely available in most microbiological laboratories. So that is why the vegetation are removed even and try to grow. If the facility is available, then axenic culture should be used. Curry fever can cause the endocarditis infection of the heart valves, which may require the transesophageal echocardiography because the left atrium is only visible in the transesophageal echocardiography. Otherwise, the transthoracic can detect it. Curry fever hepatitis manifests as an elevation of the SGPT, SGOT, and sometimes the gamma GT, but a definitive diagnosis is only possible on the liver biopsy because it is forming what is called as the granulomatous hepatitis, and it there shows in this biopsy the characteristic fibrin ring granulomas. Very specific nature is seen in the liver. It is XHSPAV normal to see the structures, the trachea, the bony skeleton, the upper zone, middle zone, lower zone, upper zone, middle zone, lower zone. Here you see this part, compared with this part. Here it is the non-homogeneous radiopacity which is seen, blocking the costophrenic angle and the cardiophrenic angle. There is this line, look this line, with the paramnemonic pleural effusion. So this is a typical, it is atypical pneumonia because it will not respond to the commonly used antimicrobials. Management of the curry fever, definitely it is antibiotics should be used, but here the antibiotics we are using are not routinely used in the endocarditis, that is doxycycline intravenously, 100 milligram twice a day at least, or a tetracycline 250 milligram should be given 4 hourly. Chloramphenicol should be at least 750 to 1000 milligram should be given 8 hourly. Ciprofloxacin, it is 500 milligram should be given twice a day, or 750 milligram twice a day, and ofloxacin 200 milligram twice a day. The unique thing is that the anti-malaria drug, the hydrochloroquine, is also used actually in the form of the chronic infection. Chronic curry fever is more difficult to treat and can require up to 4 years to treatment. You have to give some of the group. For example, doxycycline will be combined with the hydroxychloroquine or any chloroquine, and examining your eyes for the retinal detachment. Go on for the years, just like you are treating the hepatitis B infection for many years. They are using now the safe drugs, doxycycline and quinolones. Doxycycline with hydroxychloroquine is not a safe drug. It will cause a retinal detachment. You have to examine the eyes. If the person has chronic curry fever, doxycycline and hydroxychloroquine will be prescribed for at least 18 months. 18 months. The curry fever in pregnancy is especially difficult to treat because the doxycycline and ciprofloxacin are contraindicated in the pregnancy, so you have to rely with another drug. The preferred treatment of the pregnancy and children under the age of the 8 is cotrimoxazole, that is Septran, with a combination of the sulfamethoxazole with the trimethoprim. It can be used orally. This is the management strategies which we used in the. What is important is the prevention. In 70s, 60s, between a Canadian American microbiologist and virologist Paul Fist, vaccine was formed. Was instrumental in the development of the first successful curry vaccine. It is called QVax, a whole cell inactivated vaccine developed by an Australian vaccine manufacturing company, CSL Limited. The intradermal vaccination is composed of the killed Coxsackie Barnett organisms, and the skin and the blood test should be done before vaccination to identify the pre-existing immunity, because vaccinating people who already have immunity can result in a severe local reaction. That is why you have to do the IgG and IgM of these people against the Coxsackie Barnett. After a single dose of vaccine, protective immunity lasts for many years. Revaccination is not generally required. Animal screening is typically recommended, and even the animals should be examined with some same methodology. If they are infected, the same antibiotics should be used. The veterinary intervention is very important. The cleaning, the hygiene, the other things should be practiced accordingly. This was the discussion actually of one of the infections, which is called Coxsackie Barnett, causing the Q fever or curry fever. Because it is involving the heart as an endocarditis, it is important for us to detect it on the time, and the management can be done extensively to save the patient. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.